Hi, all. Thanks so much for joining Making Healthcare Work for You, Different Perspectives and Empowering Solutions. I'm Stephanie Fields, joined by my co-host, Dr. Apoorv Gupta. And today we are joined by Dr. Sanjay Doddamani. He is the co-founder and CEO of Upstream. And we almost had to cancel this interview because you weren't feeling well. So we are really appreciative that you are here feeling well and then also able to still tell us about the important work that you're doing at Upstream. So with that, why don't you tell us about the realization that you had while you were preparing for this interview, and then a little bit about what Upstream does.
Absolutely. Stephanie and Apoorv, thank you for inviting me, having me on. It's been as sick as a dog. I'm just so glad for the power of modern medication. Started all of this yesterday, and it's incredible how quickly you can recover and improve, although I'm holed in at home now for the next at least 5-6 days. I will say it just kind of made me realize how efficient and quickly I could get access to care and access to medications with a quick telemedicine visit with my physician, having medications ordered, even having a click of a button on my cell phone to press the delivery option versus, having my wife to go out and quickly pick it up, and for me to be able to take inhalers and other things to quickly get better. But just realized that the patients who we represent, who we work with, are struggling. They're older, sicker, frail elderly patients who have multiple chronic conditions. They have challenges with, multiple medications, multiple physicians, a lot of fragmentation. There's uncoordinated care. They receive phone calls from multiple people, whether it's a call center, whether it's a specialty medication, whether it's a refill or renewal of their mail order, and it leaves them incredibly challenged. And so when they get sick, they oftentimes struggle with being able to alert their physician. They're not even sure who to talk to. And our work has been so much around restoring the primacy of primary care physicians to really be the quarterback of their care. And so I think it opened my eyes even more sensitized to the challenges they face.
It's amazing, Sanjay. You in kind of like one sentence, you just laid out the stark reality of what healthcare often is for us, in terms of all the challenges that a individual patient can face. And yet we breathe a sigh of relief because we think you've got a solution out there. How would Upstream change that, right? So we already have primary care physicians. They're already trying to care for these patients. What is it that they could now do differently? For example, in the situation that you were in, would your patients be able to get care faster? Would they be able to get seen faster? Maybe you can guide us through that a little bit.
The vast majority of U.S. primary care physicians don't see one segment of the population. They see all comers. And that means that it's oftentimes difficult to tease out who are those patients who are most vulnerable, who need the extra care, the extra resources, and the extra connectivity. When we work with practices, we identify patients who are these older, sicker patients with medical complexity on multiple medications, and we develop a joint working list, what we call a nominated patient list. And that allows the physicians to at least recognize, in an electronic format that, these patients need special attention. We then outreach with our clinical teams, really led by a pharmacist, since a lot of these problems are related to medication, lack of whether it's adherence to medications, optimization of the right medications, because at the end of the day, simply visiting the doctor doesn't cure you of all your ills, right? So what you do, whether it's you're continuously, adhering to a medication regimen, improving on that, or making adjustments between visits. And so that's having that type of resource. So it's this combination of technology, combination of clinical, where we are sometimes the peer provider within the primary care practice at the point of care, and then in terms of the overall financial, because a lot of these very great resources and tools are also very expensive. And so you can't do some of this work in a purely fee-for-service environment. People have been talking for a long time about value-based care, but it is not in sort of an early sort of savings model that you can then front a lot of these investments. You really need to go into the other end, jump into the deep end of the pool in terms of full risk or taking full financial opportunity to then, or total cost of care, to then reallocate the dollars to support the tools, the infrastructure, the technology, the clinical teams. And many of these practices don't have those kind of resources, especially some of the smaller independent practices. You'd be lucky to have one or two medical assistants, far let alone nurses and pharmacists in each of their offices. So that's what we do. And it's been, I think, a really successful collaborative journey with physicians. We started this process out in North Carolina, and we're now expanding across other states.
What are some of the results that you've seen from these primary care providers that you're working with whenever you can handle this all for them and also give them the leads on what patients need this care and their attention the most?
Yeah, I very humbly submit that we don't handle all of it. We collaborate with them to make it easier, but it is true that a lot of the clinical decision making is what's their expertise, as well as establishing and maintaining the relationship and managing acute situations where there's a sudden deterioration. But it's all of the steps that they would have otherwise considered administration, whether it's closing care gaps, ordering those mammograms and colonoscopies, and improving A1Cs, and consistently forming a therapeutic workup and working that through on a very consistent basis. That's the work of coordination of care. CMS, in their rightful thinking, recognize that needs to be reimbursed in a different way, and we do that through care coordination, or CCM services. And so we bolster on those services into those practices so that they can have the resources, the people, the platform to essentially run that care management program from within their own practice. They feel very proud. It I think declutters a lot of their work. It gives them freedom to either see more patients, broaden their panel. As you know, in America, we do face a crisis in terms of the shortage of primary care doctors. We've had many different approaches: telemedicine, increasing mid-level providers, and we support all of those. But in addition to that, having, I think, a physician who can be optimal in their license and optimal in terms of the right size of their panel means that we can shift them up to be even more competitive, even more broader, by having the right resources within the practice. And one of the biggest things affecting doctors today, burnout. And this is one of those, I think, really appealing value propositions to them, because it directly tackles the burnout that they have to deal with. Never again do they have to keep dealing with recurrent calls from all the retail pharmacies or from the nursing homes and the hospitals discharging patients. You've got somebody who's a clinician sitting side by side, working through all of those things as they come in.
Is that what deters people from practicing primary care? The fact that it can be a battle to make it a sustainable practice when you have so many things to do?
It's a good question, Stephanie. I'm a clinical cardiologist. I spent a lot of time in heart failure, but because of the fact that I was taking care of a 1% of the patient population with advanced cardiac disease, and 99% were my colleagues in primary care, I became very sensitive to the work they do. They don't have the resources that hospitals have, for example. They don't have the support, and oftentimes they're left fending for themselves with a lot of challenges that face them in the community, and they have to be jack of all in that setting, which is then difficult to medically optimize patients to the levels that they need in terms of having the right professionals supporting them. So there becomes professional isolation, becomes much harder to practice, and it hasn't been also as financially rewarding. In a total cost of care model, we're moving from the traditional 3% of the total spend to primary care allocation to increasing that to 5 and 6%, so that there's more dollars for primary care physicians within one, to improve the care for their patients, 2, to be personally rewarded, and 3, to support the sustainability of all these programs into the future. So this is a mission more than it is, a company. in that we need to democratize value-based care for the average primary care doctor who's been otherwise locked out of being in a full risk or in a total cost of care model. So it aligns very much with the goals of where we're going in value-based care in the country, but there hasn't been a what I would say is a soup to nuts solution. It's been much more targeted where, hey, we'll help you on the technology piece, or here we have another tool or resource. Here we've come in recognizing these three very important pillars with sort of a fourth underlay to it. And those three pillars are the clinical, at the point of care, the financial, so that we create the right levels of incentives and support and resources, and then the technological. And then the underpinning to us is having very deep and advanced expertise in government and regulatory programs, so that we're on the right side of the law, we're following Stark and anti-kickback, but we're also, I think, appropriately enabling these physicians to be successful in the goals of value-based care.
Sanjay, there's a lot that you said there. Maybe I'm wondering if we can unpack it a little bit for our audience. It's amazing what you're doing for value-based care, a journey that the country has been on for so long, yet it feels like at the same time it's going slowly, maybe. Sometimes it doesn't feel like it's succeeding in as many areas that it could be. What is it that prevents the primary care physicians from actually embarking on this journey? And why do they need an Upstream Health to kind of come alongside and support them? Do you have offered the contracting vehicles, or is it because you have a particular technology? Or is there some other aspect that's ultimately limiting the scaling of this through the practices themselves?
Great question, Apoorva, and I want to be clear. It's not just Upstream. There are many great companies doing work in value-based care. We are one of them. But I think we've been very sensitive to what are the challenges, the pain points, because some entities, select the very advanced, very mature practices who just are a little risk averse. They don't want to put up the reserve capital, or they may not have that available to them to participate in an advanced payment model. But the others, it's not just about not having the finances or being risk averse. It's about even being able to participate where they're on the hamster wheel. They have no way of supplying the kind of requirements and closing gaps in the same way, or having the capabilities or the infrastructure. Then comes in technology like great analytics platforms that they can be harnessed into, and then what do? They tell them what to do. They tell them, these are your patients who are struggling. These are the gaps that need to be closed. These are, some of the stars and HEDIS measures that are, important for this Medicare Advantage plan. But it again doesn't give them, a way of closing those gaps. So recognizing that, we embedded our clinicians into the point of care. We let out with pharmacists some of the most difficult to close HEDIS measures that go into the CMS stars performance in Medicare Advantage are these medication-related stars measures. And so getting to 5 stars on those is extremely difficult for them, but extremely easy for us because that is our focus. That's our bread and butter. So when we come in and collaborate with them, we almost remove that off their plate so that they can be freed up, and we free them up to do what they want to do best, which is, what they love to do, which is care for patients.
So much of what we're trying to do, Sanjay, kind of like your mission actually resonates deeply with me, because so much of what we're trying to do, both Stephanie and I, through this platform and in my day job as with Guidehouse Consulting, is actually trying to figure out how we relieve that burden off of the clinicians, because they are struggling. They're ultimately overwhelmed, and many of them are getting disengaged and burnt out. And Stephanie and I have had many guests who've come on here and talked about that. So it's intriguing to me that that's kind of where you feel your solution offering is at. You may not have data at a high level, because I know how hard it is to get there, but do you have some examples or some anecdotes of physicians that you think have really been impacted in that way? I think it would be very helpful for our audience to hear about that.
Sure, happy to share. Let me start by our own employees, because we employ, right now, we're at, I think, 260 employees. We're growing to like 500-600 employees within the next few months. Our own employees, we have such amazing stories they share with us every day. We had one recent employee who I think sent back in a survey, they said that before they joined Upstream, they were ready to completely get out of healthcare and do something else, go back into retail. And that, the very sort of alignment of the mission and the way in which they could spend time with patients in an unrushed fashion was so rewarding to them. We've had pharmacists who said, we want to stop counting to 30 behind a counter, and we want to go and work with patients. When you see a pharmacist who's in a retail pharmacy, and I have tremendous respect for them, they don't have the ICD-10 codes. They don't know what the patient actually has in, sort of their background and the comorbidities. Maybe they'll be lucky enough to see the patient and then quickly determine whether there's morbid obesity or some other, based on the medications, some other concomitant conditions, but they're largely flying blind. It's this left arm knowing that, these are the conditions the patient has, doing an extensive workup, consolidating that plan, appropriately then, capturing all of those missed, diagnoses and accurately putting it together. Not just is there a financial implication that, has now come under scrutiny called risk adjustment, but this whole notion that you need to accurately capture the underlying conditions so that you can then medically optimize one by one, either the patient has it or not. And so people often think about this as just sort of, max your opportunity. For us, there's even the other way, which is we have some patients who we're actually de-prescribing. We're getting them off medications that they've been on for years. They have no idea why they're on it. We've taken patients after 6-7 years off their tamoxifen, where they should have, ended it at 5 years. We're taking patients off their PPIs, these proton pump inhibitors, where they had, their GI symptoms, cured like 3-4 years ago. And there are these resultant, risks to being on medications you don't need to be on. So I think it's the full end of the spectrum of providing that level of support to patients. But it is this concept of what is it that we bring that patients and, physicians appreciate, but even our own employees in terms of being so engaged with the care model in terms of, being there in the practice, working side by side with a physician in, in a clinical environment that's incredibly rewarding. I mean, there's something to be said about, taking care of patients. It's just an incredible feeling, being a doctor. I miss, being there with patients directly.
So Sanjay, again, hats off to you for everything that you're accomplishing. When you and I had spoken earlier, prior to this interview, actually, you had commented that you were so gratified that we were having a platform like this where we could get the message out of value-based care and how it's working. And yet you were talking to me about how concerning it is that within the literature, there's growing sense of, value-based care isn't working. Maybe we need to, retrench or do something else. And yet it clearly is working in many areas. So maybe with this kind of final shot I have at engaging with you is, can you help us think through, where it is working and why it may not be, evident, in a broader way? Or are we just studying it the wrong way? And kind of like, what is the promise of value-based care that you think a model like yours can deliver?
Let me start at the patient level, and then let me go to the community level, and then let me go to the federal level. At the patient level, we had a woman who had morbid obesity, who was turned away for a renal transplant, who has been struggling and totally disenchanted by healthcare. The very fact that she got kidney failure was as a result of a medication that her doctor prescribed for her, which was an appropriate medication. But again, I don't know where the ball was dropped, but the reality is she was on dialysis. And at some point, she just stopped taking anyone's calls, so the transplant center dropped her. In we come, working with her primary care doctor, going and attending in her home, working with her to getting her to the visits, reestablishing the connectivity with the specialist. Lo and behold, 3 weeks ago, she got her kidney transplant. So we were delighted that, this whole concept of how do we function and how do we actually serve as this bridge between the primary care doctor, the specialist, the advanced health system that did the transplant for her. And, in the process, she lost 40 pounds and got to goal with her weight. Her diabetes was near eliminated. She's now on her transplant medications in a perfect time where our pharmacist is supporting her so that she's adherent to these medications, because now this very valuable kidney has to sustain for years to come for her. So that's the patient level. On the practice level, we have seen not only burnout, but disenchantment, and the provider at the primary care level almost throwing their hands up saying, you just keep throwing more and more at me without the resources, expecting that there's a promise of maybe money one day to be made a year later, where, but you need today to be able to close these gaps, improve care, and there's a whole list of deliverables. Technology has only partially solved that. It's exposed the problem, and I think, organized it in such a way that you can at least, go off. But in-box medicine was not what physicians were trained for. So coming in to support them in those goals, closing those gaps, working with the technology, applying that at the point of care, that's what essentially we've been up to. And that means more dollars restored into their pockets in a concurrent way. That's our incentive model. We call it GAPQ. It's guaranteed advanced payment for quality that we're paying in, every month, as opposed to waiting for one day getting potentially paid. And then finally, at the federal level, Medicare Advantage, one day it's a good guy, one day it's a bad guy. There's been tremendous growth. The consumers love it. There's greater growth there. But there's this question, is there overpayments? There's a question of, should we just restore, to Medicare fee for service or Medicare for all? Where do markets come into this? And then private equity, are they good guys, bad guys? Health systems, they've been consolidating. Look at the news from yesterday in terms of, mass consolidation literally across the country in terms of health systems. Is that lowering healthcare costs? Is that actually moving more dollars into primary care? Is that actually creating the right, what I would call a safety net for patients, addressing health equity and so on? So I think at the federal level, they've, not just lost their way, they've, I think, need to be have wonderful proof points that value-based care exists. It's not just for the few elite that are nationally renowned. It can be scalable. It needs the right levels of support and infrastructure. We shouldn't give up on this. We've now been 10 years into this. There have been many promising things. NACOS has put out on how ACOs have improved quality and reduced costs. But there's even more we can do. And I think we have found that, we're very scalable, and there are others who can do this as well. And we need to push forward at continued speed to get there. In 2030, I am very confident we're going to be, and very optimistic that value-based care is here to stay, and that we'll see ups and downs and a little noise in the background. But I think consumers recognize the benefit, physicians get off the hamster wheel and actually end up being, rewarded and enjoy, I think, caring for patients. And, in the end, the country wins.
I think it's fascinating that you were talking about how patients are getting off of their medicines just because people are able to pay closer attention, because these physicians aren't so overburdened with all of these tasks that they have to do. So it's interesting that by complying to their medication and being more mindful, these patients are ultimately getting off of their medication, which is allowing physicians to have more free time and able to focus on the other people who need help. So you're kind of welling up the population, for lack of a better term. And so what does this look like in, you said 2030 value-based care is here to stay, and we're finally past that marker. But what does this look like long-term for you? Does this look like seniors living longer? Does it look like them, maybe having less medication? How does this transform? Because it sounds like it has a huge impact.
I want to be very clear and careful here. There are patients who have a total lack of access to even the right medications, who are struggling, who are non-compliant, not because, because they have bills to pay, they're having to choose. There's, poverty, there's medical debt, there's, access issues that they're dealing with, and then they have multiple chronic conditions. So those patients definitely need medical optimization, where they may need more medications, but they may need the right medications at the right doses. So it's really on, safety. it's on titration, it's on elimination, it's on medication adherence. There's a whole optimization there. But there are other patients who I think deprescribing is equally an important thing on getting them off of medications they don't need. The broader thing is that, why are we doing this work? We want patients to live longer, healthier, happier lives. And that healthcare for us is a state of independence. It's independence for the patients, for the families who are burdened. We have, I think, 20% of the US population caring for a loved one and expending 40 hours of their time per week for patients. And so, as the baby boomers age, as we have more and more patients who are older, sicker, we have to do a far more effective job so that they can achieve those goals of independence in terms of their living and more happiness. But physicians too need to be better supported to manage these patients with medical complexity. One, it frees up their time, they can get to see more patients. They are themselves instruments of care in the community that they serve. They also grow older with the communities that they serve.
Well, thank you so much for being here and sharing this. It sounds like you're doing amazing work, and I look forward to all that you're going to continue doing.
Thanks so much, Stephanie, and really enjoyed this. And I'm going to go head back to bed now after this, but I enjoyed it thoroughly. Thank you.
You're such a trooper, Sanjay. Thank you for joining us and for sharing these incredible stories of success. Thank you.
Take care.
All the best.
And thank you all for watching. We'll talk to you soon. Bye-bye.